like I guess the why of why you guys collect all this data and put it all together.
Yeah, I mean, definitely when we're fighting for the health of all moms and babies, and so we know that a lot of deaths are preventable. So anything that can then prevent those deaths is what March of Dimes is working towards. So yeah, our reports bring a lot of attention to the matter of maternity care access, and we have specific policies that we advocate for, like increasing the midwifery workforce, having less barriers for birth centers to stay open and to open.
Staten Islander News is here today with Ashley from the March of Dimes. March of Dimes is a nonprofit organization committed to ending preventable maternal health risks and death, ending preventable preterm birth and infant death, and closing the health equity gap for all families. The organization began in 1938 with President Franklin D. Roosevelt's personal struggle with polio that led to the creation of the National Foundation for Infantile Paralysis, better known as March of Dimes. They pioneered the vaccine research, leading to the eradication of polio in the US, and later expanded their mission to address issues of birth defects. In most recent decades, their mission shifted focus to healthy pregnancy and ending the preterm birth crisis with innovations like folic acid, newborn screening, and surfactant therapy. As a result of their tireless advocacy and research, every pregnant person in New York and New Jersey, and presumably nationwide, is provided with prenatal vitamins that are paid for by insurance. They're told why these vitamins are so important, and as a result, the incidence of neural tube defects and other nutrition related, birth related defects has gone down in the US. And I say that based on science. So, in fact, a 2005 study published by the British Medical Journal, or BMJ, on NIH showed that this defect had decreased by about a third in some ethnic groups in the US, largely due to folic acid fortification and supplementation. And there were other studies from 2025 as well that found the same thing. More recently, March of Dimes focuses on critical issues affecting moms and babies from prematurity and health equity to maternal and infant mortality and morbidity. They're in communities across the country supporting moms and babies with research, education, advocacy, and programs to be healthy and strong. Today, they serve as a convener to unite the nation and improve maternal and infant health in the U.S. Today, we will be discussing one of their major efforts, maternity care deserts, including their definition and the effects of these deserts on maternal mortality. We're here with Ashley Stoneburner, March of Dimes data analyst, who can help us get a better understanding of these maternity care deserts. So, good morning, Ashley. It's good to have you with us.
Thank you. Thank you for having us here.
So, first, I'd like to start by asking if you can please define a maternity care desert and what exactly that is.
Sure. So, based on the March of Dimes definition, a maternity care desert is just one way that we measure access or lack of access. So, when we say a maternity care desert, we mean an area where there's no birthing facilities. That includes birth centers or hospitals with obstetric care. And then it also includes having no obstetric clinicians. So, in our definition, we include OBGYNs or obstetric gynecologists. We include certified nurse midwives and certified midwives and family physicians who report delivering babies.
Okay, great. So, how does the presence of these deserts affect maternal mortality, and is there a connection?
So maternal mortality happens, luckily, very infrequently, and there aren't that many cases that happen each year. And since there are very few women who live likely there are very few women who live in desert areas. So that means that there's a very low frequency of deaths that occur there. So that's a really hard connection to study. However, we do know that there are a lot of other outcomes that people living in maternity care deserts are impacted by. So we know that there's been research done that there's higher rates of severe maternal morbidity, and those are near death incidents during hospital deliveries. And we do know that there is research that shows the rates are higher in areas where there's lack of access to care. We also know Archer Dimes and our team has published research on increased infant mortality among those that live in maternity care deserts. We also know that there's a great amount of stress and financial burden from having to travel so far to receive care. So there are many outcomes that impact women and families living in these areas with a lack of access to care. However, the maternal mortality link is a hard one to study.
Right, right. And actually, one of the things that really kind of took my attention with regard to this issue was the statistic provided by the American Heart Association that when no one is present at a birth, so like if a person is in a maternity care desert and they give birth at home and they have no birth attendant, there is an overall 1% infant mortality rate, presumably, because 1% of infants will need extreme help in order to start breathing. And if there's no qualified care provider there, and especially in a lot of these maternity care deserts, the ambulance also takes quite a bit of time. I think upstate New York, we just kind of found that statistic yesterday, is like 9 minutes. And brain death happens at like 5 minutes for a neonate. So if there's nobody there in that first 5 minutes, which a midwife would be, then that infant or anyone, any care provider, an obstetrician would be there, the family practice physician that you were mentioning. So, and in Mennonite communities, it can be even more severe because they don't want to go to a hospital. So even if there was a hospital available to them, they won't go to it. So that was kind of where this whole journey for us started. So what I wanted to ask is if you can briefly discuss your rankings for maternal mortality, how they're arrived at, and specifically there's like a rank like 1 to 50. The last time I checked, New Jersey was at 25, and it had previously been at 47. And New York was like 22 to 30, and it's still 30. So if you could just kind of talk about how you arrive at those rankings, and why you think if you are seeing improvements and why that might be.
Okay. So every year, March of Dimes publishes a report card. That's what we call it. And you are correct. In our report card this year, we've listed rankings, and all those are is rankings by state. So if the state has the highest rate of maternal mortality, let's say for example, they will be ranked number one or 50. They will be ranked 50. So number one will be the best rate. But when I'm looking at New York's report card and I see for maternal mortality, New York is ranked 19th out of 48. So that means that New York has the 19th lowest rate out of the 48 states that have enough data to include there. So that is for maternal mortality from a 5 year period. So the years 2019 to 2023. And that includes the COVID years. If you remember, the maternal mortality rates really skyrocketed during 2021 and 2022. So since then, the rate has declined um, quite a bit, luckily. So we see in New York in 2021 and 2022, the maternal mortality rate got up to 26 deaths per 100,000 live births. In 2023, it went down to 17. So that is a really great thing to see. Again, like I said, there's very few deaths that occur. So in 2023, there was 36 maternal deaths, and while we absolutely want zero, um, it varies throughout the year. So it's hard to see significant declines in maternal mortality because it's such a rare event.
Okay. And with regard to New Jersey, did I get that incorrect that it's 25, or is that like last year's data?
Let me pull up New Jersey. So our report cards just were published in November. So we have a new report card in New Jersey. Like I said, the rates change quite a bit. So, and we do use an aggregate of 5 years because of that. So I have 25th of 48 for New Jersey. So it's right in the middle.
Okay, okay. And is it correct that New Jersey a few years back, like you're saying during COVID, they were all higher? Was New Jersey at 47 in 2020? Because that was what I had seen previously. So that would be like a really big improvement if that's
In 2020, I'm
yeah.
seeing 27. There were
20.
27 deaths of the 97,000 live births.
Oh, but I meant like out of 48. So you said, I'm
Oh,
sorry.
I'd have to dig up the archived reports, and I don't have those in front of me. Jasmine,
Okay,
I don't know if you could pull it up from the
Yeah, I'll check the archive.
and
yeah.
25 for New Jersey, 25 is in that ranking, or is that 25 out of 100,000
That's 25 is the ranking from
out
this
of
year.
48? Okay.
Yeah. Mhm.
And where, just if you could kind of describe where do you get the numbers? Like, is it the state self-reports? Is it from hospital reports and birth center reports? Like, where did the actual numbers come from?
So for the most part, at March of Dimes, we use the national data from the Center of Disease Control, and we download those data. We either have a relationship with them and we request restricted access data, which means that we can calculate rates for at the county level. This data came from CDC Wonder, which is an online portal that you can just okay. Yeah, so for these rates for the maternal mortality rate, we downloaded this data from the CDC Wonder, which is an online portal that you can just click what you'd like and you can export out an Excel file. It's a really great resource.
Okay, so if I'm looking at this map here, just is if so it's not really specifically defined by number of miles, or this is the number of miles that each of these counties are, presumably from a birth center, a hospital, something like that. So would these all qualify as deserts that have these high numbers, or is it something else in terms of the actual numbers?
Yeah, so like I said before, so the maternity care desert designation is just one way to measure access, and then distance is another way that we can show counties where the people living in them also have to travel very far. And it's just another way to examine access. So these would not qualify. There is no threshold in our definition where a county that the average miles traveled is greater than any specific number to get to a hospital. They would not qualify as a desert based on our definition.
I see. Okay. So even though these seem like they're pretty far away, like 41 miles would be about 25 minutes if you were actually able to go at 55 miles an hour. And this
Mhm.
particular county, which is really interesting upstate, if you actually look at it, this is Hamilton County, there are
Yeah.
two roads in it.
Yeah, so
That's it.
Hamilton County is a maternity care desert also.
Oh, okay. So
Yeah.
out of these ones that are on this map and on this list, do you know which of the, because it would be presume only like three or four, I guess, because it's 4%. So it wouldn't be like the whole, all of
Yeah.
these counties.
I lost my presentation with New York, but it's Hamilton, the one that's right to the left of Hamilton, the I don't remember what it's called. It's like lighter blue, and then Seneca County was the other desert. And that's, further down. So that's why we've added distance to our calculations because we know the limitations of the definition. And another definition that's used often is being over 50 miles from a critical care hospital. So a level 3 or level 4 hospital. That's a popular one that's in the literature as well.
Okay, so it's kind of like it's not exactly based on miles, but some of these ones are far enough away and there's no. So is it possible, like, or is it the case that in rural communities that a physician, like you said, a general practitioner physician, would also just deliver the babies when they come, I guess is what you could call it?
Yeah, I
Like
think
if they're
that
not
does.
close to a hospital.
Yeah, I do think I've heard stories of that happening where a hospital is, just too far away. So oftentimes people will present at the emergency room or an EMS, like an ambulance driver, will have no other option but to deliver the baby on the way to the hospital. So I do know that definitely happens in rural areas. Um, and yeah, and that's higher risk for those babies and moms who have to deliver that way.
Right, because it's not really set up for that. If you go to a general practitioner's office, yes, you could deliver the baby there, but if you're again not close to a hospital with a
Yeah.
NICU and with that kind of special care, which presumably the physician, if he or she knows that they're going to be delivering babies, they would also just get like the neonatal resuscitation every 2 years and all of that stuff, like a midwife does or like an
Yeah.
OB does, so that they can be prepared for it. Like we actually had reviewed a film. It was called The Country Doctor, and it was really interesting. It was about what that looks like in real life. Like there
Hmm.
was this gentleman, he was a doctor in I want to say North Carolina, it might have been Oklahoma, somewhere over there by Washington State. And he would travel 50 miles to his clinic, then 20 miles to the hospital, then to this person's house, that person's house, that person's house, and that person's house because they were disabled and couldn't get to him. And then at the end of the day, he would come home with all his pile of vegetables that they paid him in.
Oh, yeah, they're heroes in communities like that.
Right,
I'm
right.
looking at our distance map that we published in 2024, and I think maybe we should give you that map with the numbers in it because I'm looking at the county that's down in the south that has 35.6 miles to
Hmm.
care, and that's not ours. Ours on, so let me just explain what happened. Since we've been a team here, we've really done a lot of work to improve the definition of maternity care access and kind of address some of the limitations of the data. And so when this report was created, um, and before that, there was never any hospital valid, the American Hospital Association, we get our data set on all hospitals in the United States from that data set that has flags for whether or not the hospital has an obstetric unit. And what we found, and what's been published by other researchers, is that that's not super accurate or always filled out. So we have validated that data using the Center for Medicaid Services or Medicare Services data set to determine if a hospital has obstetric care. And when we did that, we identified more hospitals. So between this report that you're using right here and the data that I have in front of me, there was probably additional hospitals identified, which could decrease travel time. So I think if you're using so we're updating the report this year. We're publishing another report this summer, our 2026 report. So I didn't find any closures in New York, um, like in 2025. I don't know if you know of any maternity units that have closed, but I didn't find any. So I think if we use this map, and I can show it to you if you want. All right, so this is the map that I see, and I think we can add the numbers to it because right now they're just based on averages. They're just based on these buckets. So just like your map is, but I think this one you had at a really high number of miles, and I'm not seeing that here. And then this is, I think, where Seneca is, and so this shows a higher number of miles in this region also. So I think this map would be a better one to display. Um,
Right. And I'm looking right now at that town you're talking about in the upper left. That's called St. right there. Yep, that's St. Lawrence County. And when you actually look at that one on Google Maps, over in that left side of it down there, there's like a million roads. There's like road, all highways. Up in the
mhm.
upper corner, there's not. Which is right next to that other county where it says over between 31 and 60. Up
Uh-huh.
there, they kind of probably share the same hospitals that are outside of New York up to that left part, which I don't know. I don't remember where that is exactly, but I know that some of the people in St. Lawrence have to go up to the hospital that's not even in New York.
Oh
So
yeah.
and I know that's like that could be an issue too for people as well.
Yeah.
And I know like in some communities there where they do have to travel really far, um, and the minutes. Okay, so you have it defined as minutes here. So 30 minutes to their nearest hospital, 60 minutes. What is the percentage up at the top for 30 minutes to their nearest hospital? That's a little bit above in this
Right here, 6.1.
6%. And that's in New York overall. Is that correct?
Yeah.
Okay. Okay. That means, but that's not including not pre-birth care, right? So prenatal
Yeah,
care.
exactly. It's just to a hospital. So just Jasmine, chime in if I'm explaining this wrong, but what we have done is we use the population estimate. So let's say you were saying that in the bottom left there's lots of roads. Or in the top right, maybe there's not so many and it will take those people a lot longer to get to a hospital, but maybe there's less people who live there. So when you calculate an average for a county, that spot's gonna weight less than where the people live. So that's another reason why the like you might say, well, wait, those people have to travel 50 minutes and it just says 25. It's because we have weighted it based on where people live throughout the county. And Jasmine, if
Right.
I messed.
Yes, yeah, that's exactly correct. So the actual calculations are based on the census tract that someone lives in and what their nearest hospital is, and then we aggregate it up to the county. So even though that specific, like your example, certain people might live closer to the hospital in the county, but because it's an aggregate overall of that county, when we have our statistics, like the average in this county is 15 minutes or 20 minutes,
Mhm.
that's for overall. So that might be some of the discrepancies worth noting.
Right, that makes sense. And what I was also the two towns that the two counties that I did look at was like the one with no roads. The
Mhm.
Hamilton County over there has 5,000 people, and the one with lots of roads, St. Lawrence County, has 43,000 people.
No.
Those are the only two I actually remember off the top of my head. So it makes sense, but maybe 40,000 of those 43 are all the way congregated in that area with the many roads. And I actually tried to overlay Google Maps with like the New York State highway and speed limits and stuff,
Oh,
and it
cool.
got really complicated really fast. So that didn't end up working. But then I realized that if you look at Google Maps, you can get a pretty good idea of what's a highway and what's not. And it probably has a speed limit of 45 and it probably has a speed limit of 55 or whatever, because it's 55 for most of New York roads. But if you look at them, like they're not actually that fast because they're not big enough.
Right.
And then so that's really helpful, that explanation that you provided. I really appreciate that. So what I want to do real quick is take the second chart. Um,
And just to say, like, this is with an average traffic. So this doesn't take into account when you get dumped on by snow or ice or nighttime or any changes in normal traffic. So that's another thing to just note. Like, there could be variation in travel time across the county, and it's not accounting for, I don't know, bears in the road. I'm not sure what happens in that area of New York, but I'm sure there's lots of things that can happen.
Okay, great. So this was the other map that I was a little bit confused about because it says distance to care is less for a maternity care desert, which is 15.4, and six limited access is 16 miles to the maternity care, and then full access would be 5.7, which makes sense. But how this number is smaller than this number, so I'm really confused about that.
Yeah, there's very few limited access counties, and they also have a lot of distance to travel. But I can show you the newer one
Okay.
that we actually have by minutes also. So both of the measures are by minutes.
Okay.
That was just because people had a was easier for people to interpret minutes, we found. So so we see not the same exact pattern because again, we had a lot more hospitals that we incorporated. So for maternity care desert, it's about 34 miles, moderate 26, and full 13.5 minutes. I meant
See,
minutes,
but
not.
this chart makes sense because the maternity care desert number is bigger, which
Yeah,
so
well,
it,
we
it
do
Yeah,
makes
and
see.
perfect
I'll just
sense.
add one thing that did change here with the newer data. There's no longer low access counties in New York, based on the last report. So this is just moderate access counties. So that like second category with low that was there before, those previously were combined. So low and moderate were combined into a limited access. So now you just see the three different types of counties only reflected in New York. But if you were comparing, say, to New Jersey, we might have the low access category in there as well.
I think New Jersey's all full access.
Oh yes, I see. Yep.
But I can send these slides. I will send these slides to you so that you have
Mhm.
them. So,
Yeah, that would be great. Okay. So basically, you pretty much answered all of my questions. It's a much clearer picture now of what you guys are studying and where the data is coming from and how it kind of fits together with everything. And from what you said, it's also really hard to connect why maternal mortality is happening. Is that accurate? Like in terms of like mathematically and it being related to maternity care deserts, there's probably like 100 factors that relate to obesity, diabetes, high blood pressure, and stuff like that. In addition to, and on top of maybe this makes it worse, but it would be hard to quantify that kind of thing.
We know that access to care is a huge predictor in maternal mortality, and we also know that the rates in rural areas are higher than in urban areas. But when you're looking at very small, like when you're looking at a small, like just a state or a county, it's harder to see because there's not enough people to research. So
Got
we
it.
know from the larger body of work that these are definitely factors. But when we get down to the smaller counts, it's harder to see.
Okay,
That's why we
cool.
extrapolate the findings from bigger studies to areas, smaller areas.
And part of the purpose of these studies, this research and all of that is to kind of influence policymakers to kind of help these counties get more maternal care, or is that kind of like what like I guess the why of why you guys collect all this data and put it all together?
Yeah, I mean, definitely when we're fighting for the health of all moms and babies, and so we know that a lot of deaths are preventable. So anything that can then prevent those deaths is what March of Dimes is working towards. So yeah, our reports bring a lot of attention to the matter of maternity care access, and we have specific policies that we advocate for, like increasing the midwifery workforce, having less barriers for birth centers to stay open and to open, telehealth policies, Medicaid expansion and extension through 1 year postpartum to prevent those maternal deaths that oftentimes occur before 1 year. Those are some of the policies that we advocate for, and this report brings a lot of attention to those matters.
Oh, I would definitely appreciate that. That's awesome. Because I know like with like the birth centers in New York and there was the Birth Center Act back in 2021. There's still only three birth centers for 20 million people that live in New York. Like the population of New York is 20 million people, whereas New Jersey is like there's birth centers almost like all over all over the state. And also, one of the things that I had seen, not from your guys' data, but from New Jersey's data itself, is that when they did studies on the maternal mortality, they found that 92% of those deaths were preventable.
Mm-hmm.
So something could have been done. So if there had been more, a closer hospital, better prenatal care, better care in general, those would not have happened.
Yeah,
Most of them,
exactly.
the vast majority of them. And it is an equity issue, which I know that your organization also fights for equity in that I don't remember if it's 5 times more or 7 times more, but in both New York and New Jersey, BIPOC women are 5 or 7 times more likely to die from maternal causes than white women.
Yeah,
So,
and that's the trend we see nationally as well. So, same with preventability of maternal deaths. The national MMRC data is almost 87% are preventable. So, we do know that a lot of those deaths can be prevented if women are in the right place when they give birth and if those equity issues are addressed as well.
right, that makes sense. Okay, great. Well, so I really appreciate to hear that you guys are kind of like on the same trajectory in the sense of trying to get more care for women
Yeah.
in all states. Because March of Dimes is national, right? You guys work in every state?
We have markets in many states, but we are a national organization. Yeah.
Oh, fantastic.
Yeah.
So,
Actually, can I just add one thing
Yeah.
related to what I was saying for New York? We did have staff that did advocate for the preservation of birth centers in New York. So in 2024, the Burdett Birth Center was about to close in Troy, New York, and we provided them data. And one of our staff members actually went to one of the public hearings and was able to advocate on what would happen in terms of increased travel time if the birth center were to close. And so we do know from some of that advocacy work that the birth center, it's another 5 years until the birth center is up for potential closure again.
okay, great. That's good to hear also. So, I'll be looking out for those charts from you guys when you can send them over. And do you have anything else that you would like to add today?
No, but I'm going to send you the tech notes also, so you can reference those in case you're wondering where we got data. But I'm really thankful that you had us here today, and if you ever have any other questions, we're here to support.
Thank
Yes,
you so
thank you.
much. It was
Thank you.
great to meet you both. Thank you so
It's
much.
nice
Have a
to meet
great day.
you
You
too. Bye.